We have two cases for discussion today. The first case for discussion is like this. I will present the case history now. It's a 1-month-old male child brought by the mother with presenting complaints of poor urinary stream and crying while passing urine since birth. The birth history was a normal vaginal delivery. On examination, the external examination was normal. Both testes were descended into the scrotum, and the external genitalia was normal, and the prepuce was partially retractable, and meatus was seen. Dr. Mallikarjun, sir.
Yes, Karthik.
Yeah. From here, what would be the next modality of investigation, sir? From here, how will we take the case up?
Okay. Now, the simplest modality at this point would be to do an ultrasound.
Okay.
So that should give us the kind of what am I looking in the ultrasound? Is one, I'm looking at the bladder neck, if possible. I'm looking at the bladder, whether it is full, and then how long does it take to empty, whether it's emptying fully, the thickness of the bladder, and then I would like to look at the ureters and the kidneys, whether there is any significant hydroureters and the hydronephrosis. So this and any associated anomaly. So an ultrasound would, I think, give me the lead to go about. Along with that, I would probably look at doing a urine culture.
Okay.
And a creatinine, just to look at the baseline.
Okay, sir. How important is the antenatal ultrasound in these patients, sir?
Yeah, antenatal ultrasound, if available, is of extreme importance because it will tell us what's happening. So that means if you had a big bladder or a distended bladder and someone could show a keyhole sign, then we are fairly sure that there has been intravesical obstruction, and most commonly a posterior urethral valve or a urethral atresia. Very rarely that you have children with urethral atresias who are born, but they would have probably had neonatal ascites or something because there needs to be a pop-off for them to survive. So either it's a urethral atresia or a PUV, and then you can look at the kidneys. Now the important part of an antenatal thing in the kidneys is you need to look at echogenicity. If the echogenicity is high, then you are fairly sure that these kidneys are not really what they're salt. That's number one. If they got multiple cysts, then these kidneys are not ones which are going, the child is going to survive on for a long time with normal creatinine. Or they would support the kid in their growth. So these are all we would definitely like to know in the antenatal ultrasound. Along with that, we would like to know what is the amount of amniotic fluid, what is the AFI. If the amniotic fluid was much lower, then we know that there's been definitely some amount of renal compromise. So we may have to act very early. But this child has come after 1 month. Hopefully that someone has not catheterized this particular child at that point of time, because someone has catheterized and removed it. Obstruction continues, you have the child coming in sepsis. That's the worst thing to go about.
Okay, sir. We have this antenatal ultrasound for this patient, this child, and it was showing bilateral hydronephrosis with a positive keyhole sign with algohydrominous. I have one quick question. Dr. Arun Srinivasan, sir?
Yeah.
Yeah. If this child presented at birth, what would be the time of postnatal ultrasound?
Thanks for the question. So if the child at this point presented antenatally, we would do some of the evaluations that Dr. Reddy was talking about, essentially looking at AFIs, how healthy the ureters look. Is there a pop-off valve? Pop-off valve buys you time and kidney function. And with all these evaluations, then we decide if the child can go to term versus not. There are other possibilities, including doing a vesicoamniotic shunt, which should be entertained if the child is seen antenatally. But your question is, if the child presents postnatally with these antenatal ultrasounds, then essentially our practice would be to just place a catheter right away, get an ultrasound, and VCUG to establish diagnosis. So pretty much right away is the answer.
Okay, sir. We now present the ultrasound image of this child at 1 month duration. Dr. Mallikarjun Reddy, what's your view, sir?
You have bilateral hydronephrosis, probably hydroureteronephrosis. Moderate, looks like, it's not severe. There is definitely a dilated posterior urethra here. I am not able to see the ureters in the ultrasound. So if you can see the ultrasound, so the baseline, the transverse section of the bladder, you should be able to see both the ureters. So probably the child has a posterior valve, mostly because the child is voiding, so atresia is out. So a male child, posterior valve, bilateral hydro. We are not sure whether there is reflux or is it a thick bladder and there is an obstruction.
Okay. As you said, we had the ultrasound report with us. The ultrasound report shows normal sized kidneys on both sides with increased echogenicity on the left. There is a grade 3 HUN on both sides. The renal cortical thickness is about 14 mm on the right side in the poles, and the cortical thickness on the left is around 10 mm. The bladder is partially distended and is thick-walled and irregularity. So what is the importance of echogenicity in these ultrasounds, sir?
Of the kidney?
Yeah.
No, if the renal echogenicity is... Now again, we'll have to look at the echogenicity in an antenatal scenario versus a postnatal scenario. Most of the time, these kidneys are a little echogenic in a postnatal scenario. So when someone says increased echogenicity, we are not very sure of what they mean. But we probably can just have an eye on that particular kidney, thinking that this particular kidney may not function well in future. So this has got dysplastic changes. So that's the reason probably the echogenicity goes up. That's one thing. And the corticomedullary differentiations, in a neonatal kidneys, we don't have good corticomedullary differentiation. So that is what the echogenicity would lead to.
Okay. So the echogenicity can be a marker for renal dysplasia, especially if it is the antenatal period. Is that right, sir?
Yeah, that's what is that.
Okay. Can I have a quick question with Professor Ansari?
Yes, Dr. Karthik.
Sir, we have got the lab investigations with this child, and the creatinine is around 6.3 and the sodium is around 1112. What is the immediate management for this child? And
this is what time it has been done? What was the age of the child?
1 month, 1 month, sir.
1 month. I think this 6.3 is extraordinary high, and the sodium is also very low. So I think we need to decompress the bladder, and it has to be, or the child is already catheterized or not?
Not yet, sir.
He has to be catheterized, and along with this, I would be happy to see the arterial blood gas analysis, because he will need some, not only the decompression of the bladder, but he will need some insertion of the peritoneal dialysis also. Yes.
Okay. Dr. Mallikarjun, sir, your view, sir?
I think I concur with Dr. Ansari. The only caveat here is, if someone is catheterized, make sure that the catheter has gone into the bladder. A lot of times we have seen these feeding tubes coiling into the posterior urethra. That is the only thing. But I think I cannot add anything more to Dr. Ansari at this point.
Thank you, sir. As you all mentioned, we have, as you asked before, urine culture was done, which was sterile. We have catheterized the child with a 6 French infant feeding tube, and serum creatinine was repeated after 48 hours, and it came down to 1.3 from 6.7. The child is now planned for MCU under antibiotic cover. We have got the
Dr. Karthickeyan,
yes,
I just feel that in that scenario, one other explanation for such a high creatinine with a low sodium has to be a urinary leak from the kidney. So if the child had an element of urinary ascites, that is exactly the biochemical picture that you would see.
Okay, got it. Somewhere the urinary ascites should have been there, which might have been missed in ultrasound.
Yes.
I got you, ma'am. And the
Okay.
MCU was done, and the MCU picture is like this. Dr. Ramesh Babu sir, can you describe these pictures?
Yeah, see this, I mean, ideally I would have liked an oblique film. Oblique film clearly demonstrates the posterior urethra and the anterior urethra junction, but we still could make out the caliber change in the posterior urethra. There is evidence of, valve-like leaflet obstruction causing the posterior urethra, causing the dilatation. The bladder neck it cannot be assessed properly. It would be seen very well in an oblique view, as I said. The bladder does look a little bit abnormal in shape, but not a huge amount of trabeculations. Bilateral gross vesicular reflux is there, grade 5 probably. So this confirms the diagnosis of posterior urethral valve as we suspected. Apart from that, there is nothing else I can add on this particular image.
Okay. Sir, one quick question. Is it possible to differentiate the type of valve with MCU?
See, the type of valve, the commonest type is type 1 valve. So any valve which causes this much of abnormality, both in ultrasound as well as this much dilatation, I would consider this as a type 1 valve. But having said that, it is not something which is diagnosed based on imaging.
Okay, got it. Dr. Mallikarjun sir, your views, please.
Yeah, I don't think I can add anything more to what Dr. Ramesh has told us. The only thing is the bladder definitely is abnormal. It is quite thick. So what does that tell us today is probably we need to look at a PUV bladder. So what happens when the bladder develops with an obstructed system is significant amount of the detrusor is going to be replaced by collagen. And these are the bladders which are quite thick and palpable. And if we have these kinds of bladder, a very high chance that these children will have the valve bladder syndrome, and then the kidneys probably would not come back to normal, even in spite of appropriate management of the obstruction.
Okay, sir. We have done a PEV fulguration under GA, and this is the image of the bladder. After fulguration of this child, what will be the creatinine values are provided? It came down to 1.7 to 0.6 after fulguration. The serum sodium is almost corrected. Dr. Arun Srinivasan sir, how will you follow up this child from here?
So the creatinine 0.6 is definitely it's an appropriate response, but I would like the creatinine to go down further, and it might still do so. Native creatinine has been the biggest predictive factor in terms of long-term outcomes, particularly renal replacement treatment outcomes. So that is something definitely to follow up. So I would continue to monitor the creatinine. We don't typically, as long as the hydronephrosis by ultrasound gets better, the child has a good avoiding stream, we don't typically have to do a VCUG in every one of them, and we have moved away from doing it. And at this point, it's going to be antibiotic prophylaxis and continue monitoring the creatinine and continue monitoring with an ultrasound.
So your follow-up modality will be with ultrasound, right, sir?
That's correct, yes.
Okay. Dr. Lakshmi, what is the role of DMSA in this child?
I tend to do a baseline DMSA on all patients with posterior urethral valves, probably about 3 to 6 months after the fulguration. That will give us a baseline so that we will have something to look at in future if we find that any of the kidneys are increasing hydronephrosis, or we feel that there is a change in their renal function. But other than having a baseline DMSA, it's not necessary to go on repeating further nuclear medicine studies unless there is other concerns.
Okay, so the message is clear. We will follow up the post-PEV child with ultrasound and DMSA as and when required. Dr. Mallikarjun sir, do you want to add anything?
No, I think it's all perfect. But the follow-up will continue till the child becomes an adult, at least till that age.
Yeah. As Dr. Ramesh Babu has mentioned before, the problem doesn't end with fulguration, it starts from there. So we now move on to the next case. This is a 6-year-old male child who presented with a febrile UTI. The child has no voiding difficulty. There is no constipation. The urine culture was done and has grown E. coli more than 10 power 5 colony forming urines. On complete history, the parents are giving a similar episode 1 year back. That time also the culture was grown E. coli. From here, I want to know few questions. Dr. Ramesh Babu, what will be the next plan of management?
Can you just go back to the previous slide once?
Yeah.
Yeah, so this is a 6-year-old child. And is this the first episode of febrile UTI?
Child has presented to us for the first time. This is the first time, but with history, we have a similar episode 1 year back. That also a culture proven UTI.
Okay, so this is technically a second episode of UTI. Now, the episode of UTI, what we are describing now, was this child well, or the child needed admission for IV antibiotics, IV hydration, everything, or how was the child managed?
The child was mildly dehydrated, and we have admitted and treated with IV antibiotics.
Okay, I mean, the reason I am asking these questions is this typical case of an atypical UTI where there are a lot of constitutional signs and symptoms and how unwell the child is. That dictates a lot about the suspicion of further detailed evaluation. This child, I would definitely want an ultrasound to start off. So I would start with an ultrasound as a baseline. If it shows some abnormality, definitely I need to evaluate further.
Okay. The ultrasound was done, and the ultrasound was showing bilateral hydrohydronephrosis. And before that, I just wanted to ask Dr. Manoharan.
Yes, Karthik.
Yeah. Sir, do you always do a ultrasound with patients with febrile UTI? What will be your modality of evaluation?
Of course, we have what we call it as a NICE guidelines, as you may know, Karthik.
Yeah.
And of course, febrile urinary tract infection, especially recurrent, there's absolutely no question. The first modality of investigation will be an ultrasound scan of the urinary tract.
Okay.
And based on the findings, further management will be planned.
Okay. So we have done an ultrasound, and ultrasound was showing a bilateral hydrohydronephrosis. We have done a DMSA. I just wanted to ask you, what will be the time frame from a febrile episode to a DMSA? What is the ideal time frame?
Well, it's said to be at least 3 to 4 months later. Otherwise, you're not going to pick up the damage or scars produced by the particular episode of pyelonephritis.
Is it 3 to 4 weeks or months, sir?
3 to 4 months.
Or 3 to 4 months, okay.
Because it can take that long for the scars to develop. So if you do it earlier, you can overestimate. If you do it acutely, obviously you will be underestimate very much.
Okay. Dr. Mallikarjun, sir?
Yeah.
Yep. Yeah, we have done a DMSA scan after 1 month, and the DMSA is showing a poor function on the right side with multiple scars. On the left side, there is 90% function with scars at both poles. What next, sir?
Next is obviously the MCU.
Next is MCU. Okay.
MCU.
So we have done a we have done a MCU. The
Yes.
MCU pictures are here for your view.
Yes. Now just let me. Yeah. The Scout film shows that there's no bony abnormality, but this guy is significantly constipated. All of his right colon, everything is full of fecal matter. And if you can look at the diameter of the rectum, it will be significant, somewhere about 6 to 7 centimeters, where the normal is about 2.5 centimeters. That's number one. Number two, I just could see only a filling phase of this bladder of the MCU, and then I can see reflux onto the right side, but I am not able to appreciate anything on the left side.
Okay, sir. We have the voiding flames also.
So we have a reflux on the right side, which is during the filling phase, that even in the mid filling phase, that means that it is a low pressure reflux, and this is a significantly poor functioning kidney. Now the whole issue here boils down to this amount of constipation, though he doesn't hold any residual. And the voiding looks okay. As Dr. Ramesh said, I would still love to have had an oblique film so that I could see the whole of the urethra. Now, the pending here, at this point, I would still look at treating this child for constipation before I look at anything.
Okay. Sir, do you want to comment anything about the bladder contour? Is the contour
Bladder
okay?
contour, that is slightly it's going up into the pelvis, but grossly looks okay. If you put in a magnifying glass, you probably may see a little undulations here, but overall the shape is okay.
Okay, sir. Is there any dilatation in the posterior urethra to be concerned with?
I don't think so.
It's a normal.
Okay, no. The other problem is because it's an AP film, I cannot tell you anywhere beyond the posterior urethra, but there is no wasting at the wasting at the bladder.
Okay, sir. So we have a primary reflux on the right with poorly functioning kidney. Is that so, sir? The primary bilateral VUR with the one unilateral poorly.
I am not able to see the left VUR here, Karthik.
Okay.
It's only mostly I am not sure whether it is primary. Because 6 years, he presents at 6 years with significant constipation. The X-ray shows constipation. I am not sure whether this has been because one episode 1 year back, that means at 5 years, a toilet trained child who comes with febrile UTIs. I'm not sure whether we can call it a primary reflux at this point.
Yeah, absolutely, sir. How will you account for the scars on the left side seen in the DMSA?
No, the child would have had episodes of or a previous episode of acute pyelonephritis. Now, acute pyelonephritis can cause a scar. Does not mean that he or she should have always a reflux. So about 17% of the kidneys who develop acute pyelonephritis would probably develop a scar without any reflux. So we just don't know that probably the left kidney had an infection before and then it's formed a scar.
Okay. Dr. Ramesh Babu, does it comes under VURD, this case?
See, I particularly prefer to use the term VORD only in the case of a posterior urethral valve, not in the case of a primary VUR or even a secondary VUR like what Dr. Mallikarjun says here. But I personally feel that the bladder shape looks okay in this case. I think what we have demonstrated is a grade 3 VUR on the right, but we have not demonstrated a VUR on the left. Now he has got a scarred kidneys, so I am actually worried that we are not picking up a VUR. Maybe in another VCUG or another nuclear cystogram, it would be seen. This is also a right case for a nuclear cystogram, by the way, because this is an older child who can void at will, and then which can pick up reflux much more physiological way in an easier, in a more sensitive way. but as a first imaging, I would have still loved to have an anatomical delineation here. So I wouldn't call this a VURD, but this is one refluxing dysplastic kidney on one side. That's my feeling. And if we treat that reflux alone, we probably have a risk of unmasking the reflux on the other side.
Dr. Lakshmi. Dr. Lakshmi.
Yeah, tell me.
Yeah.
Can you hear me?
Yeah, we can hear you, ma'am. Can you tell us the role of antibiotic prophylaxis in this child? Is there any role for him?
Normally, antibiotic prophylaxis is something that we would want to give to a younger child who's got severe reflux, and we think that we want to prevent scars. And even when we start antibiotic prophylaxis, most often we would be stopping that prophylaxis by the age of toilet training, so around 3 years. So here's a child who's already 6 years old. Absolutely. So I think starting antibiotic prophylaxis is probably not going to be of much help.
I totally agree. Totally agree.
Okay. Is there a role of circumcision in this child as of now?
You talking to me? Or?
Yeah, yes, ma'am. Yes, ma'am.
Well, this is the second episode of urinary tract infection he's got. And I think the first step would be to try and understand what are the other predisposing conditions. Like, for example, this child has got constipation. We need to understand his voiding pattern. So I think we need to look at all of that. A circumcision will certainly decrease the risk of the next UTI, but I think that's not the main thing that this child needs right now. So what we need is to do further assessment of the bladder and correct the bowel bladder disorder that we can see in him. And then think about, I don't know what was his post-void residue in the bladder after on his ultrasound. So whether there is a significant yo-yoing of urine and that's creating a high post-void residue. So those are all the kind of things that we need to be thinking about. Circumcision can play a role, but I don't think that's the main thing this child needs.
Okay. And circumcision, as Dr. Lakshmi has correctly said, is for a younger child where you want to buy time. This child has already reached the 6 years, so you're looking at something which you probably need to intervene at this stage. I mean, here is a case where there is a grade 3 VUR. I would have preferred a sting procedure, and that gives me a cystoscopic assessment of the opposite side also. Maybe if that is dilated, I would sting that as well. I mean, this is an ideal case for a sting.
Okay.
Maybe bilateral.
Okay. Dr. Arun Srinivasan, your views, please.
I think I agree with pretty much everyone's opinion. This is so UTI does not happen in a boy. With the length of the urethra, there is a high bar for a urinary tract infection to happen. And if it happens twice in this child, then all the possibilities are on the table. Could circumcision contribute to this infection? Absolutely, it could have. But I think the voiding dysfunction I see in the voiding images, I don't have a lateral view or an oblique view to remark about the sphincter. But again, I think that is something which we need to think about, and then it might be actually a bowel bladder dysfunction that's leading to all these concerns. So I would focus on doing a uroflow, try to find how the child is voiding, what his bowel bladder function is on a day-to-day basis. Focus on that. Antibiotic prophylaxis might buy us time when we are in the process of doing all this. So it might be more of a safety net, but if you are going to start antibiotic prophylaxis, that itself cannot be a strategy. There has to be an exit path for the antibiotic. So if you say, what, I'm going to put on antibiotics, but then I'm going to do X, Y, and Z to make this risk go away, which might or might not include dealing with the right kidney, and then you take the antibiotics off so that there is no recurrent risk of infection making the child sick. That might be a role for antibiotic, but the focus should be the bowel bladder dysfunction and what do we do with the right system.
Okay, got it. Professor Ansari, is there any role for ureteric reimplantation in this child?
Ansari is left, probably.
Okay, sir. Sir, you can take this, sir.
Okay.
Is there any role for ureteric reimplantation in this child?
I think first thing, as we all said, you need to look at to treat the bowel bladder dysfunction. Now you have a 10% functioning kidney on the right side. Do you really want to keep it? You want to fix it? You want to remove it? Is a secondary question. But the most important thing we are looking at is to safeguard the left kidney now. So this has already had taken some damage because of the infection. So we are purely looking at the cause of the infection, and the most probably it is the dysfunctional voiding and the constipation. I think done that, then we can look at what you would like to do, whether you want to do a ureteric reimplant or a deflux or a sting, which is perfectly fine in terms of whatever you would like to do. Or I think you still could offer a nephrectomy to this child. And then other important thing we need to look at in this particular child is whether this child is becoming hypertensive or not. With such a multiple scarred kidney, bilateral scars, I think we need to look at hypertension, proteinuria in this particular kid. And if that's happening, then probably we need to address that, and that would entail most probably getting rid of the poorly functioning kidney in the fond hope that things would probably be better off. But I think if you have to list 1, 2, 3, 4 here, number 1 is to look at the constipation. Number 2 is look at voiding dysfunction. Number 3, I think the antibiotic prophylaxis, as Arun and Dr. Lakshmi said, will buy you time initially. Still, if the child is actually getting a breakthroughs, this is the time probably you can look at stinging. Even that will give you a little time. But I think surgery is not the primary of any primary intent here. The intent is to treat the cause, and the cause is probably the constipation and the bladder dysfunction.
Thank you, sir. As you said before, that follow-up will be with ultrasound. And now we have come to the end of both case discussions. I now leave the further proceedings to Dr. Mallikarjun Reddy.
Thank you, Karthik. It's been a wonderful journey and a beautiful description of each one's role, and the expert in them had really put in all the things in the right perspective. Dr. Manon covered the whole gamut of postnatal evaluation of an antenatal hydronephrosis. And what we need to realize is these all make the basis for an antenatal counseling and consultations for the patients. It's a vast topic, but he has concised it nicely. Then came the most difficult part. Arun chose the topic of doing the controversies in VUR. And then if we have to discuss controversies in VUR, I think we can discuss it for weeks. But then he actually highlighted two very important parts of the thing, that bowel bladder dysfunction and high-grade reflux have high risk of renal scarring. And then he also looked at the controversies which are plaguing at this point in terms of continuous antibiotic prophylaxis. I will probably summarize saying that in a high-grade reflux, you can go ahead with antibiotic prophylaxis, look at the patient's profile and the compliance, go ahead with it, that will give you a little time to work around and see how the child is. And if you look at the review trial, all these children who, they definitely say that there can be proponents and critics of the trial, but leaving that grossly, when you look at the trial, you have these children who had antibiotic prophylaxis had lesser scars over a period of time. With that, in a low-grade reflux, I think when we talk about reflux, we don't talk about low-grade. When we talk about high-grade, it is grade 3, grade 4, grade 5. And grade 3 is a totally different gamut of fish. So we need to look at that. And the other important aspect which Dr. Ramesh Babu actually looked at is a valve bladder. It is an intriguing part of pediatric urology. Not many people can actually decipher what's valve bladder, but the few subtle important things which he highlighted, apart from getting the cases right from 4 years, 5 years, or 10 years, is that if a child develops a de novo enuresis or a de novo incontinence, daytime incontinence, make sure that, and if the child had a valve fulguration before, make sure that he is not into a valve bladder syndrome, and look at his kidneys and see how the bladder compliance and all this. And we also rightly pointed out that in these cases, Botox has been tried, but Botox does not work in cases where the compliance is poor, for the simple reason that you don't have muscle. If you have a lot of collagen, the Botox doesn't work. Then comes to Ansari's talk. Ansari has gone in a very clinical detail about the bladder bowel dysfunction. But the most important take-home message of his talk is what he has done in terms of giving the local produce to the local patient, and which is extremely important because we get something from the Western study which is not easily applicable in the particular country. So what he has given us are the local charts and the local produce which help in managing constipation. And Dr. Lakshmi has very succinctly and beautifully shown how the hypospadias should be done. And I think one line would summarize her whole method of hypospadias repair is it is very important that how you take the tissues down rather than how you put it back. So do it carefully, the hypospadias works well. With this, I would conclude the summarization. So thank you very much, and thank you all of you.